Good morning, Ada County, and all of our neighbors out there in the wide world. This is Steve Cole coming at you live from the Ada County Paramedics Education Department and Access Training Team, coming from our secret lair deep in the bowels of the secret tunnels under Chinden and Garden City. All right, let's just keep going here. So, jumping right into it, we're going to talk about things that go bump in the night, or more specifically, bump in your chest. I'm going to be talking about LVADs and total artificial hearts. So what are we going to talk about? We're going to compare and contrast VADs and the TAH. When I say VADs, that is a generic categorization, what you may commonly think of as LVADs, but there's other types out there. We're also going to talk about how to assess patients with VADs or total artificial hearts. We're going to give you some treatment strategies on how to deal with them when they're having an emergency with these devices, as well as talk about some of the common emergencies they have in addition to these devices, things that due to the nature of these devices being in their chest and their underlying medical conditions you have to look out for as well. All right, so let's jump right to it. Some basic definitions. A VAD is a ventricular assist device. You commonly think of them as LVADs, as in left ventricular device. But as you'll see in a minute, there are left ventricular assist devices. There are right ventricular assist devices. There are even as in two ventricular assist devices. There is something called a total artificial heart, which we'll talk about as well. We'll talk about bridge therapy. And we're going to talk about something called destination therapy, so you understand kind of where the patient is in their care and how severe they may or may not be. So let's jump right into ventricular assist devices. So when we talk about ventricular assist devices, it's a mechanical device that provides circulatory support for the heart. Often the heart has some form of blood pumping capability. It's just inadequate for healthy living. So you often hear people talk about a patient with VADs and their heart's in VFib or their heart's in this or that. That is actually relatively uncommon. Often these hearts do pump, just not effectively at all. This device functions in parallel with the heart, which means it provides the majority of its ventricular output, but doesn't replace it completely, although it can in a crisis. There are all sorts of multiple brands and devices. We're going to focus on the most common, but there is a field guide attached to this continuing education activity. Please, I'll reference it many times. Take a look at it. If you have an older version, I uploaded the latest version and moved forward. Now, who can get a VAD? Really anybody, as long as their chest is anatomically big enough to hold the impeller, and these are getting smaller and smaller every day. Generally speaking, you're looking at larger peds and kids, or peds and adults. The really small infants, neonates, their chest just simply isn't big enough for this. But like I said, these are getting smaller and smaller every day, so it's entirely possible that in 5 years, 10 years, that may change. So essentially, I'm going to get my little handy dandy laser pointer here. I love this thing. Essentially, here you have your heart. There you have your aorta coming off of your aortic arch with 3 branches. You have your pulmonary artery and your pulmonary vein coming off, so on and so forth. But here's the important part. This part right here, this handy dandy little bit, that is your left ventricle and left atria. Left atria up here, left ventricle. It pumps, shoves blood down here, and when it shoves blood down, it normally shoves it up and around through the aortic arch and out to the body. If you can imagine inside this 3-dimensional model, it coming up like that, the aortic valve is right about there. So it squeezes it in the direction. They implant this bypass circuit, for lack of a better term, this bypass piping here at the bottom of the heart. So when it squeezes, it maximizes the direction of flow, comes through here. This is an impeller or a pump, adds a little kick because there's no valve. It's constantly getting blood from the ventricle, and this kick pushes it up into the aorta where the rest of the blood from this is coming. So it actually provides better blood flow. So the heart's still pumping, but the heart muscle's so weak it doesn't pump well. So this supplements that. It assists that. It normally, although it can sustain life, it normally does not take over the complete function of the heart, except in the most severe of cases. So why do we care? Why is this important? Well, if you look here on the right-hand side, this is what one of the early ventricular assist device used to look like. You can see you have the device, you have a ventilator, you have patient on pump, you have pumps, lines, etc. These patients were essentially bedridden until they could get their heart transplant. That is no longer the case and hasn't been for many years. Now we have the same type of patient who is critically ill, who is essentially beyond a cardiac cripple, who is on their very last stretch of life hoping for a heart transplant. And now they're back in the home. And not only are they back in the home, they're back in the home and they're smiling and living surprisingly active lives. And we have these patients in Idaho. We have, I don't know what the current numbers are, but we have well over 60 or 70 in Idaho alone. And because our population cluster is here in the Treasure Valley, that means that that's where our population of these patients are. But not exclusively. There are some patients from time to time that live up in yonder hills. There are patients who travel through on our thoroughfares, on our lovely American interstates, going from point A to point B and stopping off in Boise, who may have these. These are definitely out there. And honestly, our local citizens, our community members, our neighbors may receive these and come back into the community. For example, this gentleman right here, who is a fairly well-known journalist in the eastern Idaho area, suffered a significant myocardial, I think he had a heart attack, if I recall correctly. I could be wrong. He had a heart attack and he had a hard time staying out of VTAC, which could be very bad, and ended up with a LVAD for a period of time. Now, he didn't do horribly wrong with it, but he was able to live long enough to get a heart transplant. Now, I want to point out something. We normally think of the patients getting LVADs as these elderly gentlemen, like right here, who are at the, I don't want to say at the end of their life, but have certainly lived a full life. There are a significant portion, and I forget, I have some stats here, maybe up to 25% or more, who are people like you and me and younger than you and me, people who are otherwise young, healthy with young children and young wives or spouses, people who are still in the prime of their life, who suffer some sort of medical emergency that destroys their heart, some sort of viral cardiac myopathy. Occasionally it's from drug use, but very seldom. I guess it could be, but lots of other reasons. Sometimes they don't know why they had this massive heart failure, but they go into acute severe heart failure, sometimes even as children. And LVADs, or total artificial hearts, are their solution to staying alive. I'm trying to break down some stereotypes there. So as I mentioned, it assists. And let's talk about the different types. So here's what you'll see. This is the HeartMate 2. They're now in the HeartMate 3, but there are still a lot of the HeartMate 2s out there. Just a little sideline. The HeartMate 2 is, as I understand it, the most common LVAD in the United States, but it's not the only one. We'll talk about some of the other ones. As I said, it's implanted in heart failure patients. This is open heart surgery. This is a significant surgery. It can't be done, or it can only be done at major medical centers. Although I have heard that here in Idaho, we may be getting a center here in the next 5 years, in which case you'll see even more of these patients. It augments the function of blood flow, and it's usually implemented for two reasons. I mean, I'm not talking about heart failure versus one thing or another, but for two goals, so to say. One is something called bridge therapy, in which it's to serve as a bridge until the patient can get a heart transplant, and often to keep them alive or improve the health so they're stable enough to get a heart transplant. Some of these patients are so unstable, they can't survive the surgery. So the LVAD actually buys them time to stabilize so they can actually get a heart transplant. And something that's relatively new in the past 10 years is the concept of destination therapy. In other words, these patients aren't candidates for heart transplants for one reason or another, either structurally or due to age or other concerns, and they will have these LVADs in one form or another for the rest of their life. Excuse me. For the rest of their life. And that's a very interesting concept as well, because some of these patients are having LVADs, and they to the point where they have to get a second LVAD because they wore the first one out. Some of these patients, and I have some stats here later, have had LVADs for over 10 years. Not a lot of them, in the grand scheme of things, less than probably 2%, but some of them have them for quite a long time and live remarkably active and fulfilling lives with LVADs. Here is the other LVAD, and this is the, God, I'm drawing a blank. Not the HeartMate. It'll come to me in a minute. But this is this particular type is the other common one. So you see it's a circular impeller, but functions just the same. Now this one is a BiVAD. And what basically a BiVAD means is you have two devices, one for the right side of the heart, one for the left side of the heart. So your heart's really sick. You also have, maybe they have a RVAD, although I haven't heard of this particularly in our area, but that's also possible as well. And then we'll talk about total artificial hearts later. Now, keep in mind that BiVAD is not a different type of LVAD. It's just right and left LVAD together. So it's basically two of these. So they have to have two controllers. They have to have, instead of two batteries, they have 4 batteries. It's basically double the trouble, double the fun. Kind of like Doublemint. Moving forward. So we talked about the 3 most common reasons why they get LVADs are bridge transplant, destination therapy, and bridge therapy. Bridge therapy may just be a few days or weeks, as I said, to stabilize, or it may be quite some time. I have a case here later that I'll talk about, actually in just a couple of slides, where somebody got bridge therapy and they did so well on the LVAD, they were taken off the emergent transplant list, and they had it for up to 6 years. While more critical patients received heart transplants, and they eventually got theirs. I have a good image of that here soon. As I said, breaking some stereotypes, not only old patients get this. This is a 12-year-old. And this was in 2018. At the time, she was one of the youngest patients, smallest patients to get an LVAD. And she had a cardiomyopathy that came on sudden. They don't know why she had it. Probably viral, but we don't know. Virus attacked her heart, and here we are. Little side note, when we look at cardiomyopathy and viruses, it'll be interesting to see in the next 10 years, looking back, if there is a spike in cardiomyopathy related to COVID, and therefore a spike in the need for LVADs. That's a little sideline. No evidence on this yet so far, but mark my words, there'll be something about it. As I said, this is the gentleman who was so unstable, he received an LVAD with the idea of just buying him time to make it to heart transplant, and he did so well. He did so well that he had his LVAD for 6 years. This gentleman is a professor. He's a botanist at the University of Idaho. He's very active, and even with his LVAD, I have other pictures, but they weren't that good, of him out in the field doing his thing with his LVAD kit on him, so on and so forth. As I said, some of these patients can live on an LVAD for over 10 years. Generally, so far there's been over 100 people, which is a small percentage compared to, I want to say there's 60 or 70,000 of these devices placed in the United States, and more every year. But still, some people live quite a long period of time. There's a lady here in Idaho, I don't know if she's still alive, here in Boise, who had just had her second LVAD and went dancing every day. She outlived her husband on the LVAD. So with that in mind, let's talk about assessment of these lovely devices. Let's talk about what you're going to do. So again, these devices, when you think about the pump, they're powered externally. So that line there, I want you to think of it like an umbilical line, a power line that runs to the pump, and the mechanics of the pump are dependent on it. So the power then comes from, so look right here, here's the umbilical line. It's not called, that's called a drive line, although there's no moving parts in it. Here is the controller. So this is the computer. This is the brain of the LVAD. And then you have 2 batteries, redundant. And the reason you have 2 batteries on all these devices so far is so you can hot swap. So if one battery is going down, you can swap one without losing power, and then you can swap the other one. And these usually have an option for AC or DC power as well. This is important to know when you look at these devices, and you have to be really careful managing these. Now you think, okay, well, how will I keep this straight? If there's all these different LVADs out there, how will I keep this straight? Well, there is a device. We're just going to call it the EMS guide. It's from the International Consortium of Circulatory Assist Clinicians, so perfusionists. These are the guys that, in addition to LVADs, these are the guys that run in intra-aortic balloon pumps. These are the guys that help with ECMO and a whole bunch of other things I'm probably not even aware of. And they put out this guide, and attached to CE, I have the latest version, which I think is either 2019 or 2021. But the latest was, I think it's 2021. And they have a color coding system. A color coding system for these. Now, they should have a sticker that corresponds to this. And in the guide, they have pages with these colors around them that match the device and the sticker they should have on them. So the HeartMate 3 is green, and it has this green border, the instructions on it. There's several pages of that. The HeartMate 2 is this orange color. The HeartWare, which is the other one that I couldn't remember the name of, that one is blue. There's one out there called the Jarvik 2000. I haven't seen anybody with any of these. I don't know how common they are, but they're on there also. They must be somewhat common because they have them in the guide. And the total artificial heart, known as the Freedom Driver, is right down there, and that would be pink, and we'll talk about that later. Very important. Use the guide. Matter of fact, go ahead and just bookmark it. I'll try to have a link to where you can get that, as well as the actual PDF of the guide itself. Bookmark it and have it handy in your phone. They often have a link to it as well, so on and so forth. And this guide is really handy if you can't make contact with the hospital that implanted it. They should have a hotline to help them troubleshoot any problems. But if you can't get a hold of them, your cell phone dies, the aliens have jammed the satellites as they're about to blow up Washington, D.C., whatever the case may be, this is your backup. So again, here's the HeartWare system. And if you remember, the HeartWare is the blue one, and you would have a blue sticker on it. Here are your twin batteries, almost like John Wick. Here's your controller coming in, and there's the disc of the HeartWare implanted pump and supplementing on into the aorta. Here is the HeartMate 2. And you can see that, again, he's wearing them under his shoulders like a pair of 9mm. Here's the controller. And here is the umbilical line, or the drive line as they call it, the master line coming into the pump. And you can see it comes off there and pumps into the aorta. And as you would expect, the HeartMate 2 should have a color-coded label on it right there to match the guide. Now, here's a really neat thing, or a really important thing. The HeartMate 2 is by far the most common LVAD out there, but I think last year, or maybe late the year before, the HeartMate 3 came out. So that is out there as well. It has the green background. As you see the border around here, it's also in the guide. So if you have an older version of the guide, which I think came out in 2016, it doesn't have the HeartMate 3. They're very similar. They're from the same manufacturer. They look almost identical, as you can see here, but apparently there's some subtle changes in the software and the controller that you need to know. The HeartMate 3 is the next generation, by the way. So let's see what this looks like for real people. Real people. So these are, here's a gentleman. He has his little side pack here where he has the, I believe this is the, I can't remember if that's the HeartWare or HeartMate. We see the controller and two batteries packed together. So I think this is the HeartWare. This gentleman right there, he actually has it in a backpack. This gentleman has a HeartMate, probably a 2, honestly. This picture's a little bit older, and you can see he has one line going to each of those, and you can't quite see it, but he has the drive line underneath his shirt going to the device. You can see a little outline there. This lady has it in a, looks like a purse. You might think it's a purse. Here's a guy golfing, and he has it on his waist like a fanny pack. So these people can live very active lives, as you can see here. This guy is just living his best life. Future's so bright he has to wear shades, and there you can see he has a HeartMate with 2 batteries and underneath his skin. Man, this guy honestly looks like he's ready for St. Patty's Day, or he looks like he should be starring across Ben Affleck when Ben Affleck walks into the room and says, I need a favor. I can't ever talk to anybody about it. We're going to go somewhere and hurt some people. And this is the guy that says, your car or mine. That's what he looks like. I love it. This young lady, man, she's ready to go out dancing. She's ready to go out antiquing. Here she has her purse, and the cable even has a nice little, looks like something like a little piece of cloth over it to keep it clean and make it blend. And it goes up underneath her dress there, and no one's the wiser. She's just cruising around. And look, these are young people. These are young people. These aren't people who, these aren't the people that you'd normally expect in the ICU. Very important for both types of devices, whether it's the HeartMate or the Heartwear, is power management. So patients will have 6, 8, or more of these batteries. And they'll keep them on rotation, very much like we used to do when we used to have a bunch of LifePak batteries. They'll usually have a couple extra sets with them if they're traveling, and they have a bucket list to knock off. They want to go traveling. They want to see the grandkids. They want to see the Grand Canyon. They want to see the world's biggest ball of twine or biggest wad of gum. They want to go out there and do it. And they're driving through Boise when they do it. Well, they probably have a battery pack in there. They may even have it plugged into the cigarette lighter. Maybe not. Maybe they want to use a cigarette lighter to light their cigarettes. I don't know. But they can plug it into their car's cigarette lighter. That was actually used to be a thing for the millennials in the bunch. Yes, you actually smoked in your car, and there was a thing that light your cigarettes, and it wasn't a vape. They also may have DC and AC power options, and they will have the AC power when they're sleeping. So they may be in a bed, and these cords may be coming off, and then they also maybe have it plugged in to keep the batteries charged, so on and so forth. Okay, enough about the things that power, per se, LVAD. Let's talk about the connections. And when we talk about connections, I'm not just talking about the connections from me to you, connections that make our life more enjoyable, the connections we form under stress, the connections we form under duress, the connections we form in the blood and the mud, although those are definitely, that brotherhood and sisterhood is definitely there. Today we're going to just talk about simple everyday connections of power from the LVAD to the LVAD control, or from the batteries to the controller, and therefore through the controller to the drive line and the pump itself. Now, if you can zoom in a little bit, or you can take a little gander, I actually want to try zoom in myself. Here we go. You will see that there are connections here. These are not just simple plug and play. They actually lock in place. They should not come undone easily. And so if they do come undone, it's usually by deliberate action. And here you can see, again, these are locking in place. Now, what's unique about this one, the HeartMate, you'll notice there's a black one and a white one there, where with the Heartwear, they're pretty much identical. Now, the reason why they had 2 batteries, again, as I said, so you can hot swap one back and forth. You should never undo both batteries at the same time. You replace them only one at a time. If you do both at the same time, it will lose all power, and the patient will suddenly become quiet. Now, sometimes we like that. We like that with a lot of our patients. We don't necessarily like it in patients that have LVADs. Yep. No, sir. No, indeed. Okay. Let's talk about the controller. Here we have 2 examples of a controller. Oops, I just jumped ahead a bit. No, I didn't. Okay. 2 examples of a controller. This is the HeartMate 2. The HeartMate 3 looks almost identical. Here's the Heartwear. You'll notice there's an alarm silence button on each of these. That's probably your friend, because these things, if things are going awry, these things are probably making lots of noise, probably more noise than a ventilator at 3 in the morning with an inexperienced medic. Yes, indeed. I said it. Sorry, not sorry. Okay, moving forward. Here we have the HeartMate 1, 2, and 3 that has this menu button to cycle through the different menu. Here you have some different buttons that help you scroll through as well. Here you have battery indicators for battery 1 and 2. Here you have just one battery indicator, things of that nature. And it tells you, it gives different menus for you to cycle through. Now, as a general rule, if it's yellow or green, the pump is running. If it's red, the pump is not running, and red is bad. Great movie. Not Red 2 wasn't quite as good, but Red was a great movie. But in LVADs, red is bad. We do not like red. When we look at the pumps, and if you're calling the hotline, they're going to want all sorts of information. One of the big ones they're going to want is pump flow. Now, pump flow, you see right here, we've got 5.0 liters per minute on this at 2,500 RPM, and it has the power rating there. But you and me sitting here, we probably have 5 to 6 liters per minute cardiac output every minute. Just sitting here at rest, that increases as our needs increase. The LVADs can be set to sustain a certain flow rate for the patient as well. And usually it's around 4 to 5 liters per minute, depending on our body size, so on and so forth. This flow parameters is an estimate. Here's why the flow may change. It may change due to activity, their needs, may change due to body position. The blood volume, hypo and hypervolemia, is a very big issue for these patients because it affects the viscosity of the blood that the pump is pumping. Frequently, these patients will be hypovolemic, and that's often a cause of syncope because they're fluid restricted. The problem being hypovolemic, the thicker the blood is, the more likely is to clot, through emboli, and of course, the harder is the pump. So, foreshadowing fluids is one of your major interventions when you have low flow rates and hypoperfusion. So again, here you can look here. What is the flow rate? Well, here on the HeartMate is 4.6 liters per minute. Here it is 5 liters per minute. This is information you will be asked if you end up calling the hotline for some reason. When you're looking, as I said, hypovolemia is one of the biggest reasons why they have low flow rates and one of the biggest reasons why they have problems. So generally speaking, if you have flow between 4 and 6 liters per minute, 5 on the mean, 5 on the average, you're probably good. If they have problems and they have good flow rate, then it's probably not the heart. It's probably not the pump. If their flow rate is suboptimal between 2.5 and 3.5, they may be symptomatic. They may be asymptomatic. Now, if they're symptomatic, it's going to be just like any other dehydration, hypoperfusion, lightheaded, fatigue. They pass out when they stand up, etc. These patients need fluids. And if it's below 2.5 liters flow, that's probably really, really bad. That's half of what it should be. They do not tolerate sitting up. These patients have all the signs of significant hypotension and will need interventions. We'll talk about what those interventions mean in a few minutes. Another thing to do when you assess these patients is assess over the apex of the heart. In other words, assess at the 5th intercostal space, just left of the mediastinum. That's where the left ventricle should be, and listen for a whirling sound. Now, these pumps do not there was a brief experiment. I can't remember if I talk about it now or later. There was a brief experiment with these pumps to see if they could produce a pulse, a pulsatile waveform like we feel. They thought that that might reduce the incidence of stroke and the patient might tolerate it better physiologically. Made no difference and actually caused some other problems. So most, I won't say all of them, but most of the modern LVADs are a continuous flow device. They have an impeller that pumps just like that, and you're going to listen. You're going to listen over the 5th intercostal space, 4th or 5th intercostal space, left of the mediastinum, just below where you'd place V2 for this whirling sound. And what that tells you is if your pump says it's doing work, but you hear no whirling, something's gone awry where the pump itself is not receiving power and input from the controller. So that's another key assessment finding. So again, you're listening for the whirling or smooth sound. You're also going to inspect where the cable enters or exits the abdominal wall and look to make sure it's intact, make sure there's no drainage, it's not cut or anything like that. You also notice that many of these patients, I wrote down some, but I actually suspect that probably most of them have a implanted cardiac defibrillator or pacemaker. Remember, these patients have an intact myocardium. They have a heart there. It's just not healthy. it may need a pacemaker to keep its rhythm, or they may have already had a pacemaker. It may need occasional internal defibrillation. The more the heart pumps, the less work the LVAD has to do on its behalf. So oftentimes they'll have a pacemaker and or defibrillator to help them. So here's some other things. As I said, it's continuous flow device. That means you'll no pulse, looking for whirly sound. You won't have a organized pleth, because again, you don't have a pulsatile flow of blood. But the pulse ox itself, because it's measuring oxygenation, will be useful. You probably won't get diastolic and systolic blood pressure. If you do, they'll both be low and close together. But a MAP, a mean arterial pressure, you may be able to get off the Zoll. We're not using really Dopplers. The moral of this story, and I say this later, so I'm going to say it now, is you're not assessing for a pulse. You're assessing for signs of perfusion. And what does that mean? Look at your perfusion sensitive organs, i.e. your skin, so capillary refill, the brain, so you're looking at their mental status. If these things are good, the pump is doing okay, and aggressive intervention is probably not needed. Putting them on EKG is useful. Well, I don't know if I say useful. It's, putting them on EKG is insightful, but you probably aren't going to do significant interventions on their heart rhythm if they're perfusing well, even if they're in VTAC or VFib. Now, I said at the beginning, you hear about patients being in VFib and doing well, but the majority of these patients have some form of organized rhythm. It's just their heart isn't healthy. So look at your perfusion. Don't worry about the pulse, and note the EKG, but don't get spun up on it. The other thing, the very big thing I'll talk about later, is assess for bleeding issues. Because they tend to be hypotensive, because they fall and they're on blood thinners, you're looking for, you're worried about head injury. These patients, because they're on blood thinners, have GI bleed issues. And honestly, these are major reasons, along with stroke, that they're often going to the ED, not for the LVAD. The LVAD is coincidental. We need to be worried about it. We need to be cognizant of it. But often the LVAD or the total artificial heart is completely secondary to the emergency. When you are doing your assessment, please, 3 bags full, be careful. Don't start cutting stuff off. Remove it carefully. There's 2 things you want to watch for. One is these patients should have a sterile dressing over where the drive line goes into the abdominal wall. Sterile, just same way as if they had a central line. Requires sterile dressing changes, etc. So inspect it. Make sure it's there. Don't pull it off unless you have to. Look for drainage, so on and so forth. The other thing is to not cut clothes off. Now, these images here, these are real images from a gentleman who was cutting his own diaper off so he could go to the bathroom. I would assume he was in a hurry. You know, he had that urge to go. But he had an adult diaper on, cutting it off, and he cut his own drive line. And as soon as he cut it, because the pump inside the patient's chest was not getting information or power from the controller outside the patient's chest, the patient's perfusion dropped. He was found unconscious, unresponsive. He was in arrest. They listened to his chest. There was no little whirly whirl sound. So they actually transported him with CPR in progress. For the medics in here, they also gave him fluids, and they did vasopressor infusions. We'll talk about that in a minute. So that's foreshadowing. But they did fluids, they did vasopressor infusions, and they did CPR. Everybody's worried about CPR tearing up the LVAD. There's not any real evidence of that being I won't say it's not a risk, but it's a low risk compared to being in full cardiac arrest with the pump not working at all. They're essentially in arrest. The concern is you'd be doing CPR, of course, and the pump was working. In this case, the pump wasn't working. So here's the really cool thing. Imagine being in the ER for this. They present him into the ED. The ER physician whipped out half a dozen forceps. Probably the janitor probably saved the day as well. Stripped the wires, spliced them back together, and got the pump working again. Got the controller communicating with the pump itself. And the patient restored perfusion, and he did quite well. Actually, let me double check that. Actually, Actually, I disregard. He had been he'd been unconscious long enough, in arrest long enough. He did not do well. Did not regain consciousness, but he had blood flow restored. So in this particular case, some interesting notes is that the wires are very finicky. They had a lot of problem keeping them in connection. That's why the forceps, and if you look in the top left picture, they're taped in place as the sweet spot. But there's actually 2 different cases of this happening in the literature. 2 different cases of very similar of this happening. So it could happen again. I certainly hope it's not from a overzealous EMT or paramedic with their super cool Raptor shears or X shears, or I can't really complain because I have monster shears myself, getting cut happy and accidentally cutting these. Let's talk about some of the other complications. One of the big ones, as I said, is bleeding. 30% of this is the most common complication, the most common reason they are admitted, is for GI bleeding and all the stuff that goes along with it, and a very small percentage site bleeding. It's because these patients have to be on blood thinners. Their risk of stroke is significantly higher with the LVAD, so they're on blood thinners to prevent that. Excuse me. So don't get focused just on the LVAD. You find a syncopal patient, ask the other questions like you would for any other patient where you think GI bleeding is a risk. The other common implication is strokes. And here's the really interesting thing is half of these will be ischemic. Those are throwing clots. And those are very common, but the more fatal ones are the hemorrhagic because of the blood thinners. And those are the ones that really do very poorly. So depending on VAD type, the incidence between 13 and 30%. The newer the VAD, the less likely it is to happen. And without going into details, basically as the technology is improved, the propeller, I should say impeller design, has improved. You have less lysing or destruction of blood cells as it passes through, and therefore less emboli. So presumably, I don't know what the stats are, the HeartMate 3 will have a much lower risk of stroke than, say, the HeartMate 2. And an older HeartMate 2, the incidence is higher than a higher HeartMate. So that's things to keep in mind. Finally, infection at the site. This is an independent predictor of mortality. If they are getting infections, they probably have poor care at home, or even if they have decent care, they're just not going to do well. Originally, this was almost half of them had severe driveline infections. Now it's down to about 20% with better wound care. This is a major cause of hospital admission, especially if they get MRSA or staph in there. And your job, even if it's a routine VAD transport, is to be observant for this and bring it to the attention of the receiving facility. This can lead to sepsis. So with that in mind, I want to stop this part of the lecture. We're going to take a break. And the next video you'll watch, I'll talk about treatment of patients with VADs. Thank you.